For those of you who've just joined us, welcome, and would like to welcome everybody to this virtual conference. There's a short history to it, and I wanted to just share that with you if you haven't joined before. We started this conference around spring of 2020, and I see Farah is here. El Shakawi was one of our residents, and Anna Budina was going to join as well. I don't see her on yet, but they during COVID had me change my face-to-face multi-headed microscope, which we were prevented from doing during COVID, to a virtual conference. And of course, my initial impression or response was one of protest, but they insisted and literally dragged me into the virtual world. And we've been doing this conference ever since. Started off with just the Penn people, and the Temple people joined as well at some point. And it's been on and off, going on for about 5 years. And then in the recent 6 months or so, we then teamed up with Diagnexia, and you see Ava is monitoring the program for us. And we're now doing it through the Diagnexia platform, which is broaden the audience and broaden the scope of what we're doing. So the way I do this conference, the way I conduct this, is to share slides that I've seen in my own practice. These slides are scanned with our local scanner. I give you a history and I share the slides, and then I invite you to share your thoughts and differential diagnoses, and that's how the conversation goes. So please feel free to unmute yourself and speak at any point. So we welcome that and look forward to chatting with you. So I actually stopping where we left off a couple of months ago in the spring. That was on June 11th, when the last meeting was held. So I'm just going to continue, and those of you who were with me during that time would know the previous cases, but that's okay. So we'll start off with this, which is a 47 male, and it's an iliac crest biopsy. And here you can see 3 sections on this scanned slide, and I'm going to take you through it. And at any point, feel free to unmute yourself and comment. Here, there's a lot of blood, and here there's some fragmented bony spicules. And I'm going to go through the other 2 as well. And I try not to give you too much of a description. I like to just point out features just to help you view them, because these are scan slides and we may not all be used to looking at scan slides. But these are bony trabeculae. You can see the eosinophilic staining of them. They're viable. They have nuclei in them. And you can see the lamellar configuration of these bones as well. The background here are some hematopoietic elements. And much of this is fragmented because the needle core obviously had difficulty getting in, and here's probably a better, well-fixed, well-structured part of this bone. Any thoughts? Anybody have any thoughts? Feel free to unmute and tell me what you think. Yeah, this is much more of the cortical bone, looking much more dense here. Yeah. Yeah. I thought I saw osteoblast, but they're not showing any rimming there. Any thoughts? So typically I ask the question, particularly with bones, asking people, what do you want? Okay. Anybody have any thoughts? Looks much more dense here. And here you can see both a combination of new bone formation with mineralization. Okay, so the biopsy typically done in the iliac crest for lesions of the iliac crest are done really to rule out either primary bone tumors or metastasis. And neither of those were present in here. This, in fact, had gone to hematopathology looking for lymphoma, and they sent it over to us. I'm just going to show you here some irregular bone formation where you can see some osteoid seams here. Okay, and this irregular formation along with these new bone formation, along with the radiology, is that of Paget's disease. Paget's disease of the bone, as you are aware, typically has a raised alkaline phosphatase, which we ask them to do in serum, and radiology concurred with that impression as well. So this is non-neoplastic, but as you know, Paget's disease can predispose to osteosarcoma. But this would be the late stage of Paget's disease where the bone is pretty much all sclerotic. The early stages where there's mainly new bone formation with osteoid and osteoblastic. And the stroma is typically very vascular in that stage. You remember from medical school days, they talked about Paget's disease as being a high output failure. And that was the reason because of the vascular stroma. And then the intermediate stage is where you see bone being laid down as well as broken down. And this would then be the final stage of sclerosis. And this would be a late stage. As you know, it occurs predominantly in flat bones, the axial skeleton, and so the pelvis, which this was from, is part of that axial skeleton. All right. Any questions or comments that people have?
Feel free to raise your hand and then I'll allow you to speak if you have a question.
All right. There's no questions. Okay, so I've had some comments there. Osteonecrosis is, yeah, would be a thought, particularly on low power, but the bone here was viable. There is a diagnosis here from Florence Norris, who's from Botswana. Nice diagnosis, Florence. Paget's disease. And then there's a question, can we get the recording of the webinar later? I defer that to Ava.
Yes,
Okay.
they'll be able to have the recording.
Okay, well, that's one of the advantages of working with Diagnexia, that this is recorded and you can see that. And that question was from Jacob, who's with us. He's one of our residents here, but he's from Addis Ababa in Ethiopia. So welcome, Jacob. How about this one? This would probably be a more approachable case. This was a left buttock mass in a 66-year-old woman. It was 2.3 centimeters in diameter. And this is a needle core biopsy of that. So again, I'm just going to take you through the morphology. Fat and blood, mature fat, some lymphoid tissue around it. You can see the pseudocapsule fairly well circumscribed. And the tumor looks pretty much the same. And I'm just going to give you an overview on low power. Okay, you can see the stroma here where there are less cells, but other areas where there's much more cells, much more cellular. And you can compare and contrast these more hypercellular with less cellular areas here as well. All right. So the other core looks similar. I'm not going to spend time on that. Just to take you down to the morphology, slowly, just to look at these cells. Okay, give you a chance to look at these cells. And then the alternating stroma, where you see the same morphology of these cells, here arranged in strands, some of them in cords, some of them in little nests. Okay, and then here, just to give you a higher power of the cytomorphology of these cells. Again, like I said earlier, I try not to give you specific details about the cellular detail pointing to a diagnosis in particular, but I allow you to think about that and share your thoughts with us. Okay. Nice round nuclei with pink or eosinophilic cytoplasm. And then back to these less cellular areas where these cords extend into this myxoid stroma. This pale bluish grayish material is mesenchymal mucin. And you can see these cords merging with that. And then back to the more cellular areas. Any thoughts?
There's a few comments in the chat.
Okay, I see EMC, extraskeletal myxoid chondrosarcoma. I'm assuming that person is put in. That's a great start. It's a little cellular for that. The myxoid areas in between would look like that. That's a good thought, and that's an important differential diagnosis, which in fact we had to rule out as well. So extraskeletal myxoid chondrosarcoma is perfectly acceptable. As you know, they carry a specific translocation involving NR4A3, I beg your pardon, and EWSR1 or TAF15. We typically have a FISH probe for NR4A3, and that was negative in this case. But that would be an important differential diagnosis. They tend to occur in the extremities. So this is in the buttocks, so maybe proximal extremity. So that's a good thought, a good start for that as well. So I have a few more here. Interesting, very interesting differentials that are put out here. I've got myoepithelioma, I've got chordoma, and chondromyxoid fibroma. Okay, let's start with chondromyxoid fibroma. Those typically involve the bone. It can be in the flat bones or in the long bones. And this is soft tissue. So I wouldn't personally think of chondromyxoid fibroma in soft tissue, but that would be a great thought given the morphology, cytomorphology of that. So those are typically bone involving. We have another extraskeletal myxoid chondrosarcoma. We also have chordoma. Now, extraaxial chordomas are well described. The cytomorphology of this are uniform and small. Chordomas, I would say, are slightly larger cells with abundant pink cytoplasm, large nuclei. They may be clear. Cords and nests do fit with that as well. And they also have, as you know, that famous physalliferous bubbly appearance, which this has some bubbly appearance here, but not quite within any of these cells. So if you had any doubts about chordoma, if you wanted to prove that, remember you can do the epithelial markers S100, and both of those would be positive, including EMA, epithelial membrane antigen. But the key stain for chordomas is the brachyury, which was negative in this. And so extraaxial chordomas have been described, and that's again a very important differential diagnosis. And then the third or fourth one that I'm coming to here is soft tissue myepithelioma, which has been offered by a couple of people, and that's exactly what I called it eventually. Oh, there is a myxoid liposarcoma. So again, the myxoid liposarcoma would typically have a stroma which is characterized by the chicken wire or thin, delicate vascularity. This doesn't have that. Also, unless you're thinking about a round cell sarcoma, which is a high-grade myxoid chondrosarcoma, for the cellularity to go along with that would be a thought. But the absence of the chicken wire vascularity makes me move away from myxoid chondrosarcoma. Again, you could do FISH if you have that luxury, and probe for DDIT or CHOP as the old term was called. There are no specific markers for myxoid liposarcoma, but there are antibodies available towards the DDIT protein that you could purchase and use as well. So the final, and some of you have suggested that as well, the soft tissue myepithelioma is correct. And that's exactly what this is, and this is what we called it. And that was based on both the demonstration of epithelial markers and myeloid markers. Oh, I love the differentials that people are putting up there. Thank you. That's very kind of you. We should talk to us, but that's fine. Seeing your differentials in the chat works as well. And so, as you know, the salivary gland myepitheliomas may carry a PLAG1, which is a gene rearranged, carrying in a fusion, as well as HMG-A2. So this was PLAG1 rearranged, just to confirm that it is a soft tissue myepithelioma. So any questions or comments on that? I love your differentials. They're all very good differentials. Excellent discussion. Okay, it's nice scrolling through all of that. All right, and if you want to talk, I think Ava wants you to put your hand and then unmute you. I think the system demands that it's done that way. All right. Ava, is there any way of having everybody muted, but they unmute themselves? Is that possible?
It seems like if I unmute, everyone's cameras come on, so it might interrupt the quality of the presentation.
All right. Okay, we'll stay with this and we can talk about that later. Okay, any other questions? Soft tissue myepithelioma. Remember, these do occur in the soft tissue, and this is purely myepithelial, but they can be mixed with the glandular and other heterologous mesenchymal components as well. But the differentials, I'm really pleased with the people bringing in very appropriate differentials in the context of cells and the stroma, which are all very appropriate and pertinent. Okay, let's see how you do the next one, which is 920. Here we go. 920. Let me just close the chat so you can all see this. So this is a pelvic mass. I don't have a size for you. Patient is a 75-year-old woman, and I do not have a size. I apologize, but a pelvic mass it is. And this is a section from that pelvic mass. Just trying to determine where we are, and I think I know where we are. Right, it says pelvic mass, but this looks like myometrium. All right, I'll give you that. This is in the myometrium, and seems to have overstained or overscanned the color. But you can see this huge mass here, as well as these islands of tumor involving the myometrium. So we can go anywhere here and just look at this closer, higher power, just to see the cytomorphology. Mainly spindle cells in this area. Okay. Again, feel free to give us your comments. I'm going to just open the chat so I can see that live. Okay. There is a question from the previous one. Do you always do IHC for differential diagnosis on EMC and myepithelioma? That I'm just going to address that question because that's a very pertinent question. Thank you for bringing that up. Just referring to the previous soft tissue myepithelioma. In truth, apart from the NR4A3 fusion gene, the real only way to distinguish EMC from myepithelioma is with the stains. And the epithelial markers and muscle markers are very useful in that context. S100 less so. Remember in the early days, they talked about EMC being S100 positive, but they realized that it's only about 20% or less. In fact, it's very rare to see S100 in EMC. So the answer is yes, you have to do immunohistochemistry to help distinguish between EMC, exoskeletal myxoid chondrosarcoma, and myepithelioma. And in our case, that was evident and very nicely discernible. Okay, so I answered that question, and I've already got some excellent thoughts here. Smooth muscle neoplasm. endometrial stromal tumor, low-grade endometrial stromal sarcoma. Those are all good. I'm just trying to find you. Find you other morphologies. Yeah, there's some areas here where they look a little more sort of epithelioid and round. Okay, so smooth muscle is a good start up there, and I'm just looking at leiomyoma, schwannoma, SFT, schwannoma, MPNST, smooth muscle differential diagnosis, atypical leiomyoma and leiomyosarcoma. So smooth muscle, yes, would be your first thought, and I always, when looking at uterine mesenchymal tumors, rule out smooth muscle tumors. And my go-to panel for that is, of course, Desmond and H-Cal Desmond. I like H-Cal Desmond because it does have a sort of a better marking potential in uterine smooth muscle tumors. So I use both those as well. This was SMA, which is smooth muscle actin positive, and just to give you that and CD10 was negative. I'm just looking to see where did I see yeah, here we go. Endometrial stromal sarcomas, typically the low grade are CD10 positive, and of course you can always resort to FISH for SUS12 and JAZF1 and PHF very rarely, but those can occur. Here, there's some epithelioid cells here as well. Not I hope, coming through quite nicely as well. Let's see, malignant schwannoma. So schwannoma and malignant schwannoma was put through on the chat. The S100 was negative, but MPNSTs, as you know, may be very patchy, if at all, focal S100, if at all. There's another leiomyoma, schwannoma, SFT have been described in the uterus. There was a nice paper from Boston, Harvard group. One of our residents, Kyle Devins, published a small series of SFTs of the uterus. So good to keep that in mind. And again, easily resolved with CD34 and STAT6. So you can always sort that out quite easily. Then there's a pecoma. Yeah, that's interesting. Pecomas. So pecomas, as you know, occur in the uterus and have been well described in the uterus, pelvis, soft tissue, and then, of course, all the other sites of pecoma and angiomyolipoma and lymphangioliomyomatosis, etc., etc. So they've been described widely, but the uterus has become, a sort of prominent organ where it's been described in recent times. And when you think of that, then you would define a pecoma as being myelomelanocytic, and it has to have that biphenotypic profile. So you want myoid muscles. We got the SMA and some patchy Desmond, and of course the myelomelanocytic markers were positive as well. So I typically like to do 3 or 4 of them. I don't confine myself to just HMB. I like to do HMB and melanA, and we also have MITF here, so we can use that. And a good marker as well is cathepsin K, which is not specific, but in the context of pecomas, they are useful. So that's what we called it. We called it a pecoma or a pecoma, as some people call it, just to show you a little more sort of cellular areas and more epithelioid looking cells here as well. And by definition, myomelanocytic in its profile. Okay, just to show you some of these areas here as well. Myomelanocytic and more plump and eosinophilic as well in these parts. And then, of course, you know that these carry the mutations involving TSC1 and TSC2. The reason I mentioned that, there was a nice paper by Marissa Nucci not too long ago, like a year or 2 ago, saying that even if you had patchy focal HMB45, that you should resort to sequencing them, because those are TSC1 and TSC2 anomalies do form a platform for rapamycin mTOR inhibitors for treatment of these. anyway, I'm jumping ahead of myself here. The next thing you do when you make a diagnosis of PCOMA is then stratify it. Is it benign, uncertain biological behavior, or is it malignant? And there's some nice papers out there. You can look for the risk stratification of PCOMAs. Initially, they used to use the FORP criteria. Andrew FORP, many years ago, published his criteria based on size and mitosis, necrosis, atypia, invasion, etc., etc. And those were applied to the uterus, but those have been now adapted and adopted and modified. So there's a couple of papers out there that address the risk stratification for PCOMAs of the uterus, and I would suggest you Google that, and those papers will come up as well. So those are useful. Just a last parting shot before I address a last diagnosis suggested there is that whenever I see something abnormal in the uterus, and I'm not talking about the high-grade uterine sarcomas that involve YWHAE or even BCO, I'm talking about tumors like this where you're not sure whether it's benign or malignant, and it's not smooth muscle tumor, or you're happy it's not smooth muscle tumor. I then ask myself, is it a PCOMA? In which case I do the melanocytic markers, or is it a UTROS, that uterine tumor resembling ovarian sex cord tumor? I do that, and for those I do mesenchymal. That's again Desmond and Acton. I do the sex cord stromal, inhibin, and its steroidogenic factor 1, SF1, and then epithelial marks. So those really are positive for those three. You could resort to genetic testing for those as well. It's ESR1, I think, and GREB is much less, but GREB1 is the other gene that's involved in that. I've not used any of those molecular tools. I typically look at morphology and my immunohistochemistry to make a diagnosis of UTROS. We've seen a handful here over the last few years. And then the other thing I ask myself is it IMT, inflammatory myofibroblastic tumor? So that's the other one. Whenever I see something looking a little funny, abnormal, then I go through that sort of differential. Just sharing that with you in terms of approach for these peculiar uterine tumors. Was a nice review, by the way, in Archives. I think it was earlier this year. A very nice review looking at mesenchymal tumors of the uterus. Archives is free on Archives of Pathology, uterine mesenchymal tumors, and that paper will come up. It was earlier this year. It's very nice. Goes through all of these things we've been talking, including the high-grade uterine sarcoma. So a good review for trainees going for boards as well. I just want to address this final last differential one, and I appreciate you putting up your differential. I really do, because it helps the conversation going as well. FH, fumarate hydratase deficient Lyme. Excellent thought. Typically, I know some people do that routinely. I typically would do that if I saw atypia. And if I saw atypia in a smooth muscle tumor, then I would resort to FH. We have the antibody, and remember, it's lost. So in the Krebs cycle, the anomaly to this gene is loss of the protein expression. 2SC is a step before that, and if you have that, it's overexpressed. So some people have that. We don't have that. We have just the FH, and it's a good screening tool. Remember, the FH loss does not mean that the patients have the hereditary leiomyomatosis syndrome. For that, you've got to sequence germline DNA for that. But at least you could point towards that, so patients could be screened. And then more recently, I think in the last year or two, people have been saying that the antibody is not specific for FH deficient leiomyomas. So I'm just putting that out there. But yeah, if I see the morphology before I make a diagnosis of leiomyoma with bizarre nuclei, I would rule out FH deficiency. So in the context of morphology, we make that diagnosis based on morphology and the loss of FH. So good differentials, and appreciate that. Any other questions? Whoops, I shouldn't have put that off. Any other questions or thoughts? Please feel free to speak or put it on the chat. How are we doing with time? Okay, we're doing very well with time, Ava. It's 1:32 on my side. I know it's later in Africa. Those of you in Africa. 4110. Okay, let me just open this out here. This is a bit of a challenging case, but you guys, I think, can be challenged now. So let me show you this case, and you can tell me what you think. Oh, I've got some marks here, so I've been here before. These are nice because you can do this with these scan slides, which are one of the advantages of scan slides. Or digitized slides, as they call them. So this is you've all spotted the colon here. I'm sure you've all spotted the colon. What's this guy doing with colonic polyps? 46 female, and that's what this is. This is a colonic polyp. You can see the polypoid nature of it, the surface of the mucosa on that side. And I'm just going to go down for you just to appreciate, yes, there is a colonic mucosa. There's a submucosa. It's a normal sort of submucosa, a little dilated, ectatic, lymphatics, some inflammation, likely because it's polypoid. But then as you drive down here into the stalk of it, it looks extremely cellular. On this side of this polyp, I think this is ulcerated mucosa. Some exudate on the surface, inflammation, lots and lots of chronic inflammation. And then I'm going to go dive deep down into the central core of this polyp, okay? And here we go. So let's perhaps start here. You can see some lymphoid aggregates here. Oh, these are germinal centers. So they stimulated, just to share that with you. And the stroma in between has lots and lots of plasma cells and lymphocytes. And then the rings are there deliberately, and I'll come back to that in a second. Here you can see some inflammation, plasma cells. Oh, I forgot to open my chat because I love you guys commenting as we look at this thing. All right, nobody has said anything yet. I'm going to keep this to one side. I don't know if you can see this chat screen when I drop it. Okay, I can put it to the side. Oh, that's good. Okay, so here we go. Here we go. Hyalinized stroma with plasma cells. Okay, and there's one other feature I want to show you. There's another germinal center in there as well. But some of these areas here, I just want to go down on higher power, just to take you through a few more cells, just to give you a better handle on what's going on here. Of course, I can't find it on the screen now, but they are there. Some of these cells, I hope this comes across to you. These larger cells, you can see is nuclear membrane quite prominent to the nucleolus. So they're much larger than the plasma cells and the lymphocytes in comparison. And let's see if we can find you more. But you can see these sheets and sheets of plasma cells here. Ooh, I see some diagnoses kicking up there. Nice. I like your response there. Okay. All right. So I've got follicular dendritic cell sarcoma, and I've got Castleman's disease. So the Castleman's is a good thought. And here again, you can see this hyalinized stroma with vessels. And is this hyaline vascular Castleman's? That's a good thought. I don't know, but that's the reason I show these areas. There were some follicles which showed or suggested a little bit of the onion skinning. Not the best. We've seen better, and that's a thought as well. But let me see if I can find you more of these large cells. Here we go. All right, these. Oh, okay. I've got the cells marked out. This is impressive. Yeah, I showed this at one of our ICCs. We have an interesting case conference. I must have shown it a couple of years ago. But here you can see these big cells, prominent nucleolus, vesicular chromatin. This has got 4 nuclei, prominent nuclear membrane, and they're quite easy to find under the microscope. Here's more of them here. Here's more. That's got multiple nucleoli, and you can see a somewhat irregular nuclear membrane there as well. All right, so I've got follicular dendritic cell sarcoma. I've got Castleman's. Anybody wants to add to that? Okay, you all know that oh, I've got Rosai Dorfman. Welcome, Anna. Anna, I spoke to you and Farah being responsible for this conference. So 5 years in the making. Thank you very much. I'm sure everybody is pleased that you started and dragged this conference into a virtual reality. Rosai Dorfman disease easily addressed with an S100, as you know. Cyclin D1 is the other marker for Rosai Dorfman disease. Adam Bagg published that in the breast some years ago. Let's look at some of these cells here. Here we go, these larger cells here. So the follicular dendritic cells, histiocytic cell sarcoma. Okay, that's a good thought as well. And for that, you'd need histiocyte markers. We typically have CD68, IB1A, and CD163, and I believe there's a CD14 as well for histiocytic cell sarcomas. But nowadays, it's becoming increasingly more difficult to make that diagnosis. And I know some people would want to have a background of, one of the lymphomas or myeloid leukemias in order to have a diagnosis of histiocytic sarcomas based on a backdrop of that. So we just have to watch that space. But and again, for histiocytic sarcomas, you want sheets and sheets of large-looking abnormal cells. RGD easy to rule out with S100. We talked about that. And then you want to see emperipoiesis. They have abundant cytoplasm with a prominent nucleolus in that as well. And then there's other variants of histiocytic sarcoma, dendritic, that's follicular dendritic cell sarcoma. I've got IDC, which is all left to S100. The follicular dendritic cell, just to mention, CD21, CD35, these cells are positive for that. And but there's one other marker I want you to mention. There's an extranodal malt lymphoma as a possibility. And what else do we have? I'm just looking to see. Okay. And then, of course, Castleman's. Castleman's, I did raise that possibility as a possible background of Castleman's, but I'm not sure about that. Follicular dendritic cell sarcoma, yes, it is, but this is a variant of that. And this is the so-called inflammatory variant of follicular dendritic cell sarcomas. This case was given to me shared with me, by a hematopathologist, for which I was very grateful. Vinod Pillai, who's one of our hematopathologists at CHOP, shared this with me a while back. And the stain that you want is EBV, Epstein-Barr virus, and the in situ hybridization that we have for EBV was positive in those large cells. In fact, there are far more of those large follicular dendritic cells than meets the eye on H&E. And so this is an EBV-associated inflammatory variant of follicular dendritic cell sarcoma. Now, before you say, what's that? It's a variant that was described a long, long time ago by John Chan. He's from Hong Kong. He's that famous surgical pathologist with the hematopathology caps as well. But he's excellent in a wide variety of things. But John described that variant in the liver and spleen many, many years ago. And they look just inflamed like this. And you remember in the old days, we used to call them inflammatory pseudotumors. But these focal EBV positive dendritic cells were highlighted with the Epstein-Barr virus. And of course, CD21, CD23, 35 confirming that diagnosis. And for many years, that's how it remains, that these were described in the liver and spleen and always formed the differential diagnosis of inflammatory lesions of the liver, which would include things like IgG4, syphilis, and et cetera. But this is one of those that you have to think about. And I remember many years ago asking John, well, how best would you identify these dendritic cells in this mass of inflammation? And he said EBV, that's the best marker. And they light up, and that's how you make your diagnosis. Now, swing all the way back to maybe 2-3 years ago, and these were being described in the colon in polyps. They do very well, apparently, and the AJSP has got the EBV-associated inflammatory variant of FDC. And if you go AJSP, those papers will come up. There was a couple of papers, and they expanded them to the upper airways. So there was a couple in the, one in the tonsil, one in the upper airway bronchus. So just to be aware of that. And if you see something like this involving a mucosal site in the aerodigestive tract, think of that and do an Epstein-Barr virus. And if it highlights these large big cells, then do the CD21, 35, 23, because that will help you identify follicular dendritic cells. So here I was probably just being a little more looking for, could we see a background of carcinomas? And I the suggestion of carcinomas, I like that. And I wondered whether that was here, because that's not been described in this context. Carcinomas, as you know, typically mediastinal or intra-abdominal, and then from those about 20% develop FDC sarcomas, and those have a context of well recognized as well. But whether these EBV associated inflammatory variants arise from carcinomas, we do not know. But it was tempting to think of that in these hyalinized areas here like that. So it was tempting. With the plasma cells, it looks like it. I mean, yeah, somebody agrees with me out there. Mark Heaven, thank you. I like that. Oh, there's an amyloidosis, and that again, eosinophilic dense hyaline material. Sure, amyloidosis you have to think of, and again, quite easily ruled out with just doing a Congo red. I'm just scrolling back up just to see a differential. It was a round cell tumor. Differential diagnosis, amyloidosis, follicular carcinomas. I think we addressed everything. IDC, of course, is only S100 and morphology. And of course, if you can find in a lymph node, if you can find the interfollicular zones with that, it's always nice to find that starting up there. It's also useful. Yeah, it came from my lymphoma colleagues. So when anything comes from my lymphoma colleagues, I do not go looking for lymphoma. So I expect they would rule out lymphoma. Thank you for that as well. And converse too, if we find lymphomas in soft tissue and bone, we send it to them. All right, any other questions or comments on that EBV-associated inflammatory variant of FDC sarcoma? All right. It was also known as inflammatory pseudo-tumor-like. That's what John Chan called it in the early days. But I think now WHO is using EBV-associated inflammatory FDC. So keep an eye out for those. You might find them. Once you're thinking of any questions, I can go to my little scroll here and pull out another case. I think we have 14, 15 minutes. So 169. This is a case, if I can find it. Oh, there's it here. Okay. Thank you. Thank you. Okay, what do you think of this one? This is an interesting case. Fascinating. I still find it fascinating, and I think of it every now and again. It's a wonderful story, and I'll share the story with you. Let's see what you think first, okay? So this came from our sister hospital, CHOP, which is a Children's Hospital of Philadelphia. This was a young lad who had these multiple lesions in the vertebral body, liver and spleen. And this was a biopsy from his spleen. So I'm just trying to check what his age was. 15. He's 15, is a boy, a young male, 15. And these were two of those nodules from the liver. And here you can see liver tissue, just to convince you that we are in the liver. All right, that's all liver tissue. A little irritated. It's sort of looking a little, here's a portal tract for those liver non-luminal GI pathologists. And here's the lesion. So just to show you a low power, you can see the lesion here. I'm trying to outline it because there is a lesion here. And I have some marks here as well. So obviously been here before. And I'm just going to show you these areas on high power. And then you can tell me what you think. And again, I'm so grateful for you putting your differentials and your thoughts on the chat. I do appreciate that. Much, much appreciated. I would prefer to be face to face with you all on a multi-headed microscope so we can chat and have fun, but this is fun enough. All right. Is that the highest power? Oh, this is even closer. Right. Remember, he's a young man. He's 15 years old. And these are multiple lesions in the vertebral body, liver and spleen. There is one piece of information I'm just holding back on. I just want to see what people think. Okay, I've got epithelioid hemangioendothelioma, EHE as we abbreviate it. Good thought, good start. And I'll address differentials as they come up. Two thoughts to that. These form lumina. You can see little vessels. Okay. And also the EHE typically has cords and nests, but embedded in a chondromyxoid or myxohyaline stroma. You may argue there is a myxoid stroma here. Yeah, you may. Okay, okay. Not forming cords and nests, but fine. If you wanted to do a CAMTA antibody, remember there's an antibody to CAMTA, you can do that. Or if you have fish, luxury of fish, you can probe for CAMTA. So we're starting off with EHE. Okay, good thought. And then we have epithelioid hemangioma. Again, another good thought. They also would have vacuolated cytoplasm. They can form lumina as well. Also very plump, eosinophilic, epithelioid. I'm glad everybody's going on the vascular route because it is vascular. So I'll share that with you. Now, here's the piece of information because I've got two differentials to kick off with. Anybody else have any other thoughts? Yeah, you can see it looking a little epithelioid, yeah? So forming a little lumen. So I can see why epithelioid hemangioma was. Speaking of which, I think we have a nice one in the vertebral body with our fellow Brits. Anyway, a piece of information I'm holding back here is this patient had a renal transplant. So does that? Oh, we've got angiosarcoma. It doesn't look too ugly. Okay, I accept angiosarcoma, but it doesn't look ugly, and you know, dare I say, somewhat lobulated as well. Okay. All right, so we're seeing Kaposi sarcoma or Kaposi's. I like that. Ooh, I love this here. Bacillary angiomatosis. I love that. So KS, let's look at KS, okay? KS is lobulated as well. It's kind of giveaway. They form slit-like spaces. You do get vascular changes typically in the periphery of a KS. This is within the lesion. This is within the lesion. Well-formed vessels, small vessels opening up their lumen, well-formed. And then, oh, look here, this might be a residual liver cell. I don't think that that's part of the lesion. But within these areas, some of these nuclei look very epithelioid, very epithelioid. I've got two more here. I've got vascular angiomatosis and Kaposiform hemangioendothelioma, which can occur in children. Kimuras, we can keep that mainly soft tissue. I've not seen that in organs, but those are also good thoughts. All right. And Kaposiform hemangioendothelioma, yes, they look like Kaposi's. Let's look at Kaposi's, and again, easily ruled out because you can do an HHV8 these days and you can rule that out. Typically spindled lobules, short fascicles, and they have hemosiderin and plasma cells in the stroma as well. And they are multinodular as well. So you can rule that out in this context because I mentioned renal transplant and you all went for immunosuppression, but somebody here went for bacillary angiomatosis. Thank you very much. So some of these looked epithelioid, and that's the reason these are marked out. They do look epithelioid, which bacillary angiomatosis typically does look epithelioid, and pleomorphic. Endothelial nuclei are pleomorphic. But what this does not have, although in parts, I wondered whether I'd seen eosinophilic material in the lumen, and you sometimes see that eosinophilic detritus in the lumen of, oh, there's a nice one here. There may be a little bit of fibrinous material here as well in the setting of bacillary angiomatosis. So that is what was suggested, and PCR for, Bartonella was sent off, and lo and behold, that's what it came back. Came back as Bartonella quintana, not Hensela, but quintana. So this is bacillary angiomatosis in a setting of renal transplant with immunosuppression based on the drugs that they use to suppress the immune system. And this kid developed multiple lesions of bacillary angiomatosis in his vertebral bodies, liver and spleen. And he was treated, and these, I believe, resolved as well. So the story doesn't end there, because I told you this was a fascinating story as well. And the bacillary angiomatosis, BA as I call it, the ones I've seen have been really much, much more epithelioid in the endothelial cells, and also the fibrinous material has little neutrophils with it. Some of these look, but that's a nucleus there, I think. Yeah. So this was just a quiescent one, and I don't know if that's because of the immunosuppression or not, but the follow through was that PCR was positive. It was sent to the Mayo. It was also sent to the CDC, and that's where the story starts. Because with the CDC, so just to those not in the US, is the Center of Disease in Atlanta, Georgia, and they did their PCR as well, and they actually confirmed the species, which was Bartonella quintana. Bartonella quintana. And that's what the organism was, confirming bacillary angiomatosis. And then that's easily treatable. In my time, they used Bactrim, but I don't know what they use nowadays. That was cotrimoxazole with one of the other antibacterial agents, but I'm not sure what's used today. But anyway, be that as it may, CDC then was able to put together, because remember, people do not know where kidney comes from. Okay, that's all sort of HIPAA rules, and you don't know the families, and you don't know where these come from. But CDC was able to match where the other kidney was donated. Okay, and the other kidney was donated to a gentleman in Boston, and CDC was able to track down that clinic who was following that gentleman with that kidney and test him as well for Bartonella quintana, and he had antibodies to that. So he was treated for that as well. I thought that was fascinating because the kidneys that came from the patient obviously had that infection, Bartonella quintana, and this was transmitted to the recipients of the kidneys via the transplant, and then they developed these bacillary angiomatosis. I thought it was fascinating. It makes a good story. By the way, that was published as well. So if you put in bacillary angiomatosis, Bartonella quintana, transplant, kidney transplant, that paper will come up. I've forgotten the name of the journal. Sorry, I cannot remember the name of the journal, but you can find that. It's just a fascinating story. For me, it was a fascinating story of detective work, medical detective work, where if it was not sent to CDC, who then identified who the other recipient was, that would not have clicked in that respect to identify the other patient. This was a fascinating story. Okay, so any questions on this or any of the other cases? Yeah. Anybody, any questions on this or any of the other cases? Happy to take on any questions. Everybody seems quiet today about questions, but whilst you thinking about that, I think Ava will allow me to share with you that the next webinar or conference we have or same time, Wednesday, 17th September, which is my time, 1 p.m., 1300 hours Eastern Standard Time, EST. So 17th September is the next one. Look forward to having you all join me. And thank you for being part of this group and your differential diagnosis, for partaking. I just enjoyed your differential diagnosis.